Everybody, welcome. We're already chatting. I'm Sasha. Welcome to the APTA Animal Physical Therapy Podcast. I'm Sasha, the president of the Animal Special Interest Group at APTA, and I have with me tonight Dr. Alana Struble and Dr. Kristen Kirkby-Shaw. As you guys join us, if you'll please pop your names into the chat and tell us if you are practicing PTs, if you're a different license group, if you're student physical therapists, so we know who we're visiting with. And we will get started here in just a few minutes with our podcast as you guys join us. So what we're talking about this evening is the peek behind the scenes. And so we're already talking, the two doctors and myself, about what does it look like behind the scenes in the veterinary world for physical therapists. It's a whole big different ecosystem. And when I was a brand new PT, the way I stepped in is my sister was a dog trainer. She was working in a veterinary hospital. So I went and started taking dog training classes so I could learn to speak dog in her vet hospital. In that way, I met the veterinarians who worked at the veterinary hospital. And then when I became certified, I asked them if I could come shadow them or watch surgeries. And it probably took 2 years before I was practicing. And that worked out really well for me. I felt really confident in that way. So let's go ahead and get started with our podcast tonight. As you guys are scrolling in, if you'll pop your names into the chat so we can see who's here with us and what your license group is. Hey, Carrie, thanks for joining tonight. So tonight we're happy to have this peek behind the scenes with two really incredible veterinarians. I want to welcome Dr. Alana Struble, who's coming to us from California. You can see she's got her beautiful background there. If she bends to the side, there's a dog. Yes. A nice German Shepherd dog on the beach. And Dr. Kristen Kirkby-Shaw, who's just most recently joined us at CSU. We're going to have a conversation tonight about what does it look like behind the scenes in the veterinary world. But before we do that, let me introduce these two amazing veterinarians to you. Dr. Alana Struble is a highly accomplished small animal veterinarian who's been practicing since 1995. She has a deep, lifelong commitment to integrative medicine, mobility care, and whole patient wellness. She earned her DVM from the University of Illinois and has extensive postgraduate training, including veterinary spinal manipulation therapy, acupressure, acupuncture, sports medicine, geriatric rehabilitation, and orthotics and prosthetics. She's a certified canine rehabilitation therapist and an active member of multiple veterinary rehab and acupuncture associations. Beyond her clinical expertise, she's known for her work in animal behavior and learning theory, which she integrates into every rehabilitation plan. She approaches each patient holistically, reviewing imaging, medical records, and conditions such as endocrine disease to understand how the entire body contributes to mobility and recovery. Her passion for client education is unmatched. She excels at explaining the why behind neuroanatomy, acupuncture, and manual therapy, empowering owners to fully participate in their pet's healing process. She also has made profound community impact. She founded the Veterinary Street Outreach Service, or Vet SOS, which is an insanely cool name and does insanely cool work. And she has served on multiple nonprofit boards. She's widely recognized with numerous Beowulf Beast of the Bay Awards, honoring her as one of the most trusted and innovative veterinarians in the Bay Area. We're thrilled to have her perspective tonight on what veterinary practice looks like from the inside, and she is practicing animal rehabilitation, so you'll get to see what her world looks like as a veterinarian practice animal rehab, and how does she work with physical therapists? So thanks for joining us tonight, Dr. Struble.
Yep, happy to be here.
Our second amazing doctor joining us tonight is Dr. Kirkby-Shaw. She is past president of the American Association of Rehabilitation Veterinarians and currently serves as the president of the Veterinary Orthopedic Society. She is the founder of CARE, Canine Arthritis Resources and Education, a leading global platform that offers evidence-based tools and practical guidance for managing canine OA. And you PTs can join CARE. She is one of the most respected voices in small animal orthopedics, sports medicine, and rehabilitation. She is board certified small animal surgeon and board certified specialist in veterinary sports medicine and rehabilitation. She brings the rare dual perspective that integrates surgical excellence with movement science and long-term recovery planning. She earned her DVM, MS, and PhD from the University of Florida, where she also completed her small animal surgical residency and developed an early passion for physical rehabilitation. She went on to create small animal rehabilitation services at the University of Florida, which, Kristen, we know that's not easy. Good job, good job. And she later co-founded Sound Veterinary Rehabilitation Center in Seattle, where she practiced both as a surgeon and a rehab specialist for nearly a decade. She is a longtime instructor for the Canine Rehab Institute and has lectured nationally and internationally, published widely in orthopedic and rehabilitation literature, and is co-editor of the forthcoming textbook, Canine Osteoarthritis and Pain Management, A Practical Approach to Diagnosis and Management. And that'll be out next year?
Yeah, sometime in 26.
Yes.
Very exciting.
One of Dr. Shaw's core messages is that rehabilitation is inseparable from high-quality orthopedic care. That's so fun to say. I'm going to say it again. Rehabilitation is inseparable from high-quality orthopedic care. She has practiced as a rehabilitation veterinarian for as long as she's been a surgeon and considers rehab essential for both perioperative success and non-surgical patient management. We're thrilled to have her here tonight as well to see how she integrates PTs into her practice. Thanks for joining us.
Thank you for that introduction.
You're welcome. So PTs, I see you guys streaming here into the chat. Will you guys pop any questions that you have for the doctors here into the chat? And I will integrate them into my conversation as we're moving through the questions. Shall we begin? What question shall we begin with first? Let's start with a super easy one. Dr. Shaw, how does a pet flow through the system when they show up for an appointment?
Well, I think we have to clarify where, like what type of appointment. So I will give the two examples that I'm familiar with. One is the university setting, which is where I work now, and the other is a specialty hospital. So neither Dr. Subel or I are general practitioners, so it's a little bit different. But no matter what, when they show up, the very first person that the caregiver will encounter is the receptionist or client services representative, CSR, which is the more current name that we're using for receptionist. So caregiver meets the CSR, and the client and dog or cat will usually then be put in an exam room or wait in the lobby. And the next person that they'll meet is usually a veterinary technician or veterinary assistant. And that individual will come into the exam room. They will collect an initial history. They might take a heart rate. They might collect some of the vitals. Then generally that person will go back in the back to the doctor and relay what the initial kind of history presenting findings were to the doctor. Then the doctor comes into the room, and it works a few different ways depending on the clinic, whether the dog is taken into the back for a physical exam or it remains in the exam room where the doctor comes in to do their exam and communication with the client. In the university setting, There's a few more steps in there because insert students, interns, residents. So there's a few more steps along the way, but that's the general flow.
And so, Dr. Struble, you have a rehab clinic, a veterinary rehab clinic. So what's the workflow look like in your ecosystem?
So my ecosystem, so I'm formerly a general practice vet. And so I know from being a general practice vet that my first thought was not to refer straight for rehabilitation if I had a dog with a mobility problem. It was to first refer to orthopedic surgeon or to a neurologist. So if the client's dedicated and they want to know more about why their dog is having problems, or their vet's not sure and they want a second opinion, they'll usually go first to a surgeon or neurologist who then either offers them a surgical solution or says it's not a surgical case. Why don't you go to see Dr. Alana and do physical rehabilitation for conservative, they don't call it conservative management, but non-surgical solutions. Or the clients will say, egads, I can't afford this surgery. Are there other options? And sometimes the surgeon will say, sure, you can go try physical rehabilitation and orthotics. Or sometimes they'll say, nope, there's no options. And then my clients will go on Google, and then Google will refer them to me, or their dog walker, or their pet sitter, or the friend at the park whose dog had a knee brace and they want to know how they got that instead of surgery. So that's my ecosystem flow. And then what happens is they'll email my team, because I started as a mobile practice. I didn't have a brick and mortar. And so I have a remote client services representative who's sort of the genie who makes all the pieces fit together for these appointments. And she'll reach out to client inquiries. We'll do an initial appointment by telemedicine, which I started doing during the pandemic. And I have to say, I really love it, because I have a chance then to go through not only all their x-rays and lab work and records with the client before the dog and the client arrive at the clinic. And then they're not as focused. They're busy worrying about what the dog is doing or eating, So on Zoom, I can show them radiographs that they haven't looked at yet. Half the time they've never seen their dog's radiographs, especially during the pandemic, or even met the surgeon sometimes, but it was really hard. And now post-pandemic, we're still using the Zoom because I find there's so much to discuss about their questions, their goals, their expectations. What do they want from rehabilitation? So we spend a lot of time on Zoom first at 45 minutes, and then they come for an in-clinic visit. And so then the next time I see them, they're coming in the door here that same week, usually a day or two later, for an evaluation and treatment. And then hopefully they'll encounter one of my animal rehab assistants, although we're so busy that oftentimes they're in and we're just shouting across the gym, we'll be right with you, so we don't always have someone sitting at the desk. But it's a very, fun, welcoming environment when they walk in. They see dogs having fun, playing games, doing treadmill, getting treats. And so that's the experience. They walk into more of like a gym setting, and then they'll see me.
Nice.
Yeah, so that's how it goes.
And so, Dr. Shah, will you pick it up from there? And now let's take it from the referral to the orthopedic surgeon. And what does it look like then?
Yeah, so I think Alana sort of nailed it in terms of the options that an orthopedic surgeon will give. But the surgeon will do their exam, go through the history, will usually review any radiographs, x-rays that have been done prior, but often we are notorious for wanting to take our own set of x-rays that are well positioned in the way that we want them. Generally, there's some sedation involved. And one thing that both Sasha, you and Alana have a background in behavior, and I have such a strong appreciation for that. I've gotten much more into it in the last, let's say, 10 years. But most veterinarians, and certainly most surgeons that I know, don't. So we rely a lot on sedation to do some of our palpation. And most surgeons are not trained in the advanced palpation techniques that UPTs are. So it's, pretty standard, list of techniques to do. So we'll combine that with our diagnostic imaging, then the kind of classic orthopedic approach is it surgical or not? If it's surgical, go talk to the client, give them the recommendations. There's usually a gold standard that surgeon will feel is appropriate, whether it's a total hip replacement or a TPLO, may or may not talk about other options from a surgical standpoint. And then if they say it's not surgical, or the client says, what else is there? I can't afford surgery. It's not in the cards for us. Then hopefully these days, they are given an option to go for non-surgical management to rehabilitation professional. That being said, I know there's still a lot of surgeons out there that are not referring. So clients are going to the Dr. Google to find Alana and other animal rehabilitation practitioners.
Mm-hmm.
One thing I'll say that I forgot to mention, and Kristen, I was wondering if you were going to mention, but sometimes then they come to me by way of referral from the neurologist or the orthopedic surgeon. So say they are a candidate for surgery, if they do surgery, some rehabilitation is often recommended in the discharge notes, and some are more proactive. Some surgeons like yourself, Kristen, or some others I work with will say it's imperative your dog have physical rehabilitation for best outcome. Or I'll get like, the doctors gave me a list of rehab facilities and you were on the list. So but I have a close relationship with a few, and they'll text me and say, I have a patient, can you squeeze them in? And so that's the kind of relationship that you want to, you want to collaborate and build that relationship. So I always squeeze them in. But yeah, so that's another way in this ecosystem that we get our client referrals.
Yeah, I think, that's a really good point, because it is becoming much more common that a practice will have a list of rehab practices. And so I worked for about 6 months in a specialty hospital in North Carolina that had no in-house rehab, which is honestly why I didn't last there, because I can't practice anymore without it. But we did have a list, and we would hand out that list. But we didn't actually, and none of the doctors there had a really strong relationship with any of the people on the list. And so it was sort of this like, I don't know, here you go. Call whoever's closest to you. There were 1 or 2 people on the list that we would say, well, I would circle them and say, I know this person, at least I know how they were trained, so to check them out.
And I guess one other thought, Kristen, in that referral list is sometimes more and more locally, at least, they'll have mobile surgeons come to practice to do TPLO. And so the general practice is hosting these complicated orthopedic procedures, and they're being asked by the mobile surgeon to do follow-up radiographs at 8 weeks. And sometimes they don't get a recheck with the surgeon at all. And if the dog's not healing as the general practitioner would expect them to at 8 weeks, they'll say, your dog's not using the leg still, should be doing better, or has a lot of atrophy. Why don't you go see somebody for rehab? And they'll send them my way if they've worked with me. So, or they'll give them a list of rehab practitioners.
Yeah. And before we move on, y'all, I want to highlight a couple of points here that I don't want to get lost in the conversation. We're visiting tonight with 2 highly skilled professionals that have been working in this field for many, many years, and their language regarding rehabilitation, physical therapy, and veterinary medicine is meticulous. So we have all these different terms, right? Veterinarian belongs to licensed veterinary professionals. Physical therapist belongs to licensed physical therapy professionals. Rehabilitation is the overarching term we use to encapsulate all of those things. But I just want to give these 2 a shout out, because this is something we have worked on for so many years to get straight, and it's effortlessly falling off everyone's tongue. So thank you. Thank you.
Yeah, I mean, we had good teachers, I think, in the training that we went through. But I have the practice that I mentioned most recently. I got in there and I was like, they have physical therapy everywhere written in their medical records. And I was like, no, we can't do that. Nobody here is a physical therapist, and nobody on this list that we're handing out right now is a physical therapist. So yeah.
And sometimes you'll find people on that list who are neither animal rehabilitation practitioners or physical therapists. They're just really people who enjoy doing fitness or swimming dogs in a pool, and so clients will get confused, or even referring vets that, oh, I'm referring them to a swimming pool, that's physical therapy, or that's one form of physical therapy, but they're not getting any of the physical therapy techniques that we've been trained in. And so
Right.
hard to explain that to the community without,
and I think this is a PR message we're working on from APTA level, but I just want to give a shout out to the community here with you two visiting tonight, because it's just so refreshing after all of our years of trying to get the language right, that it's working so nicely tonight. The other thing, physical therapists, I want to highlight that it's really hard to understand until you step into the veterinary ecosystem is these two veterinarians are talking about diagnostics like it's easy. And it is so hard in animals. I want you to think about doing an evaluation clinically without getting any subjective feedback. You can get some meaningful information from the way a patient reacts, the way a dog reacts or a cat reacts, but diagnostics are king in the world of veterinary medicine. And it's just really difficult to explain until we start to do some clinical work together in these podcasts, how meaningful diagnostics in those clinical evaluations are. When Dr. Shaw says to us, oh, there's this clinical list of like these tests that we do that are standard orthopedic tests. Those tests are not easy to interpret. Like, you can clearly learn how to do them, but interpreting them requires the diagnostic step. So I just want to lay that out there, that they're making it sound easy. It's not easy. And both of them are highly skilled in this. Anything you two would like to add before we talk about how physical therapists are going to fit into this ecosystem?
Well, one thing I would share, because listening to Kristen's perspective, having to sedate patients, there's a big difference between an animal rehab patient walking into a standalone rehab clinic versus walking into a veterinary hospital or university. First of all, my floors are not slippery. I don't do any sedation of any kind here. So I don't do radiographs or other imaging. And it's on my hands. And so I have to form a calm rapport with the animal. I have to have a fear-free, force-free way to evaluate them, because I'm not doing a sedated orthopedic exam. So if they come to me from a general practice and they've never had a sedated orthopedic exam, I'm trying to help diagnose what I can feel with a relaxed patient. And if they're too stressed and too anxious, you can't interpret, you can't get much laxity. But when you do spend an hour, hour and a half with the patient, which doesn't usually happen in general practice or specialty practice, they do get relaxed. Play games for 20 minutes first, give them treats. Next thing you know, they're on the floor for belly rubs, right? And I've learned this from you, Sasha, and other my instructors from Canine Rehab Institute who are PTs, how to relax a dog so they can let you assess their body and give you feedback. Like, yeah, this feels great. I'm going to close my eyes, or nope, I don't like that. I'm going to tighten up my muscles and look right at you. Like, what are you doing? Yeah. So that's the feedback I'm relying on. And if I can't get enough information, then I have to refer them back to the vets. Like, hey, I need more imaging. I need some imaging. I need sedated orthopedic eval to confirm this.
That's a really great point. Slick floors are my absolute pet peeve. It is my soapbox. And when I had my own rehab practice in Seattle, the dogs wagged their tails coming in. They were pulling their clients, caregivers through the door. They loved being there. And then when I step into my surgery world, it's the exact opposite, because they know it's a clinic. They know that it's not the same type of environment. So yeah, to the PTs out there that aren't familiar with a standard veterinary practice, it's not somewhere that most dogs want to be at all. So it does take earning their trust. Through all of the low stress handling, fear-free techniques that are out there.
And I find that also allowing clients to stay with their animals, first of all, most of them are more relaxed. Some of them are more anxious and they're trying to climb up their parents' lap, and it's better to separate them. But whenever I can, I keep them together because not only can the animal relax, but then the client can see what I'm doing, see my evaluation, and I can teach them things while I'm going and explain what I'm feeling.
That's my preference as well, but I would say it's not for most of my colleagues.
Yeah, it's not the norm in general veterinary ecosystems.
Yes.
Even in some veterinary rehab facilities and within specialty clinics, they don't have the space. They're doing it in the treatment room where there's extra stuff going on, and they can't have owners walking around in there. So it's definitely nice to have a standalone rehab or a separate rehab facility within the specialty hospitals like what you have, Sasha.
Yeah. Yeah. I think Sophia's got a question that's pertinent to our topic now, and then Carolyn and the rest of you that have posted questions, we'll get to those soon. When more diagnostics are needed, when would you refer back to the GP vet versus a specialist? And what's the main difference between a consult with an orthopedic specialist and sports med specialist?
You want me to tackle a little bit of that first? Okay. So the question is, when I refer back to the GP versus the vet specialist, if they've come to me from the GP, then I'm going to refer them on to the vet specialist because the GP's referred them to me for my opinion, and I'm on the fence. Is it LS? Is it lumbosacral pain? Or is it hip? They both look kind of off kilter on radiographs, or is it both? Are they candidate for surgical procedure or not? Do they need to see the neurologist? Is LS disc disease? Is it warranted to do some interventions here? And so I often refer to a specialist back rather than back to the GP. If it's something that's just very straightforward, like I just want to see if this poor dog has a bone tumor or, some other reason why this feels the way it does, then I'll send them back to the GP. And I have a couple GPs who I collaborate with regularly. And otherwise, though, I'm looking for an orthopedist or neurologist. And I don't have I have one sports medicine specialist in the area, and she's primarily doing joint injections now. And so I refer to her if I feel like imaging, like musculoskeletal ultrasound and joint injections would be helpful. But I don't have the sports medicine specialty readily available in the area, is what I would say. How about you?
And Dr. Shaw, do you want to, since you're both an orthopedic specialist and a sports medicine specialist, do you want to talk about what are the differences and similarities?
Yeah, so I think starting with the sports medicine specialist, or even just trying to be specific about terminology. And so the word specialist is implying that you're a diplomat of the American College or European College of fill in the blank. And so a rehab sports medicine specialist is someone that's board certified. And it's a relatively new specialty in veterinary medicine, and there's a pretty wide range of people that have that specialty. More and more, it seems to be going towards the realm of diagnostic. So at CSU, our rehab sports medicine team, which is called orthopedic medicine and mobility, their big focus is on those diagnostics. So if you were referring a case to CSU that needed more diagnostics, it would go through the rehab sports medicine group. There are not that many out there is the thing. So as Ilana mentioned, there's not that many rehab sports medicine specialists. A big chunk of them are actually, similar to me, double boarded. So most of the time, or a lot of the time, is spent doing surgery, but we also have this interest in rehab sports medicine. So if you're choosing between the two and you have a rehab sports medicine specialist who has the capability to do advanced diagnostics, whether it's CT, musculoskeletal ultrasound, those are probably the two biggest ones, potentially arthroscopy, that would be a great option. If it is more of a neurologic concern, those cases are generally going to need an MRI. So a specialty hospital that has an MRI is going to be the first choice. An orthopedic specialist, surgeon, should be trained, should theoretically be able to do it all. We are trained in doing that all. It's finding ones that have the interest in diving deep and figuring out what's going on, versus wanting to kind of stick with the more classic cases. So ultimately it comes down to who's in your neighborhood and getting to know who's who, because they're each going to have preferences. And if you have a specialty hospital where you have neurology, orthopedic surgeons, plus or minus a rehab specialist, you can refer. Actually, I would say just develop a relationship and understand who wants to do what. One more thing I would say, and this may not be clear and maybe why you're sending them, is what the diagnosis is. So Alana gave the example of, is it a hip or is it an LS? And so a case like that, you know, that's on the fence. That's a harder one because it is ideally going to need an MRI, but maybe we can get it from CT, versus what we call a shelbo, which is basically any thoracic limb lameness, which is going to need a CT plus or minus arthroscopy, plus or minus ultrasound of the shoulder. So that's a pretty big workup. No orthopedic surgeon out there enjoys the thoracic limb lameness. I can tell you that, because it's not straightforward. It's rarely one single thing. And sometimes it's a neck. Sometimes it's actually a neurologic condition. So long story short, there's not a clear answer is kind of what I'm getting at. It's going to be about who you have in your area and knowing what they have the capability of doing.
And then to overlay the physical therapy licensure piece. So based on what state you're in, you're going to refer through your referral network. So in the state of Colorado, even though I work at CSU inside a specialty teaching hospital, if I get an external referral from a GP, on the medical clearance form, we ask the specific question: if I find something that indicates the problem might be outside the diagnosis that they sent, do they want me to send it back to them, or do they want me to get a consultation with a specialist? So I'm letting whoever referred to me make the decision about where they want me to refer the patient. And that works very well because the veterinarian who's in charge of the case gets to make the decisions about where the patient is going, and it keeps those lines of communications really clear, and that seems to work well. A couple quick questions from the chat. Hey, do you guys see cats?
I do.
I do.
I love cats. Cats love, well, first of all, I like acupuncture as well. Cats love acupuncture, but they also really like manual therapy.
Yeah.
They love mobile joint mobs. They love all the techniques I learned in my rehab training, as well as my chiropractic or CVSMT, veterinary spinal manipulation.
Yeah.
They love it. And they also tolerate e-stim. They really like e-stim. And so if they've had surgery and they have significant muscle pain or myofascial, like trigger points contracture, they like e-stim. They do like shockwave, unless they're really gooey, and then they have to spend hours clearing their long fur from the gel. But yeah, I've had a few in the treadmill. I can't say they love treadmill. I've had a few do really well because they really like the food. And they do like the laser modality for arthritis. So yeah, cats are great, and rabbits. And I know, Sasha, I use your rehab videos. I've not had a turtle or a parrot or a hedgehog patient, but if I do, I know where to get my information.
Poor birds, they get osteoarthritis in their claws, and then it's very achy to perch. So laser for those little darlings is super helpful. What about you, Dr. Shaw? What kind of not dog patients do you see?
Yeah, so at the moment, none. But when I was in Seattle, one of the highlights of my career was when I got my own name badge for the Woodland Park Zoo or the Seattle Zoo. And so I used to consult and go up there. And so gorilla. So we taught the gorilla various different therapeutic exercises. And it was interesting. He did not tolerate a class 4 laser. So we had to be very cautious about which laser. Komodo dragon. So Komodo dragon also got lasered in acupuncture. Penguins. Taper. Yeah, so some pretty cool things.
My fun one were the otters. I got to treat river otters. Yeah. So cute. They learned how to do all their therapeutic exercises. They were very clicker trained. And then most recently, I've seen a cria, which is a baby alpaca, and a goat. And the noisiest patient I've ever seen was we had to put a paralyzed pig in a wheelchair. The pig loved the wheelchair, but that was a very squealy ordeal.
I forgot my favorite was a red panda. So red panda was
panda. And you have to say, living in the Bay Area, I'm surrounded by a lot of like farm sanctuaries and animal sanctuaries. So I've seen a number of goats and sheep. And once you get like known as somebody who will make an orthotic for a goat or will do rehab for a sheep, then they start passing the name on. And so I've seen a number of those cuties. Some come to my clinic and we sneak them in the back door because I'm in a shopping plaza, and others I do farm calls occasionally because it's up in wine country. So why not?
Yeah, why not? Why not? So let's talk about how do the two of you integrate physical therapists into this veterinary ecosystem? And then we've got a few important questions in the chat that we can answer for the PTs about this. So Dr. Struble, how do you collaborate with, I know you do some training of some PTs. How are they integrated into your ecosystem?
Well, so what I would say is that unfortunately, because California law will not allow PTs certified in animal rehabilitation to practice without the direct supervision of a veterinarian, meaning on the premise.
Which, just side note, board meeting tomorrow, PTs, with the PT board. So we're working on it. Go ahead, Dr. Struble.
And I'm a big advocate. I'm working with Karen Atlas on that. And I'm a big supporter of the Animal Physical Therapy Coalition. But nevertheless, at the moment, if you advertise that you're practicing without being under the direct supervision, somebody will report you and you'll get a cease and desist letter at the moment. So in California, if you're in California or other states, then you do need to work within a veterinary practice, and so, or a standalone rehab practice like mine. I would love to integrate an animal rehabilitation trained physical therapist. I love working together, collaborating. And it's hard because I think a lot of the animal PTs that I've worked with here who want to do their own thing have moved out of state, or they're doing their own thing in some other way, or working at a specialty hospital. But if I were to be able to hire someone, I'm always advertising for physical therapists. So if any of you want to move to the Bay Area and come work with me, just get my information afterwards from some.
Do it. We'll put it in the show notes.
I'm desperately looking for more skilled animal rehabilitation professionals to work with me, and to do intakes. To do them together, to do them separately. The PTs that I've had hosted as an intern, many of them they don't have the confidence yet to do an evaluation on their own of an animal and make, a treatment plan. And I find sometimes patients are coming to me for a diagnosis. They want to know, why is my dog lame? They still don't have an answer. They've been to see a surgeon, a neurologist, they've done all kinds of imaging, and they're still they're not clear about what's going on with their animal. And so I think sometimes it's helpful as a PT to collaborate with the veterinarian. And then I like to ask the PTs for their skill set and how would you treat the soft tissue problem? How do you do your myofascial release? And so I'm doing trainings all the time with my local animal PT friends coming to my clinic and doing, workshops for us or with us. So there's many ways I would love to see more collaboration in this area. Yeah.
Great. What about you, Dr. Shah? How do you integrate PT?
I call you.
I know. Now we do. Now we just walk down the hall, right?
Yeah. Well, so yes, now I'm extremely fortunate to get to work with you and your team. But before that, in Seattle, I was also very fortunate to hire a PT on our team. And she was fantastic. And I guess I'll sort of describe her journey to get there. As she practiced as a PT, owned her own practice for decades, and then was kind of like on the tail end of her human career, and interested in what is this animal rehab. And part of her, in order to kind of gain some experience, she went and volunteered at the Humane Society in the local shelter just to get experience with dogs, dog handling. How do you even walk a dog? How, you know, a lot of those behavior things. And then she actually approached us and said that she was interested in at least shadowing and volunteering and watching, which was phenomenal. And so we got to know her and she got to watch us. And then she thought, well, yeah, actually, this is something that I do want to pursue. So she went through CRI training, and then we hired her back on. And, you know, I think she was very humble about coming in with like knowing what her skill set was and what it wasn't. And it just allowed, it really opened up for us to collaborate. Because I remember there were so many cases, as Alana mentioned, that the soft tissue component, the myofascial component, which I admittedly, that is not my skill set. You know, I know some rehab things, but the manual stuff is not my skill set. And so she was always involved in those. And so the way that it worked in our ecosystem in that practice was all of the cases came through and had an evaluation with a veterinarian, a rehab vet. So it was myself and a few other rehab vets. And then we would decide, is this a case that it's a post-op TPLO, pretty standard, they can just come back in for the kind of classic post-op rehab, or is this a case that's a bit more involved? And we would refer them to Peggy. And so that they would come back, and she had her own column, her own schedule, where the cases that we thought were going to benefit from her skill set would fit best. And I was very, very fortunate to get to have that.
Mm-hmm. I guess you just made me think about the fact that, you know, if I don't have Sasha in the building, I will email someone like Sasha, or I'll go online. There's a lot of online resources by my PT colleagues, Lori Edge Hughes. I can't live without some of her videos. I learn, I'm like, oh no, I think this is a Terry's major injury. I've never treated one. What do I do? And I go look it up, and sure enough, she not only has a video explaining it, but showing on a dog how to palpate for it. Mm-hmm. So I'm learning from my PT fellows, even if they're not in the building, or I'll reach out to Karen, like, I have this weird case, how would you manage this? I do reach out to my animal rehab PT friends more than my veterinary rehab friends for advice. You are my mentors, Sasha and Jenny, Jenny Moe. All of my rehab PT friends are who I learned from. So,
and I think that's the piece. We can get to Keegan's question now. She was asking any advice you veterinarians would give an animal PT for establishing a good relationship with a local veterinarian. I mean, from my perspective, when I stepped into the veterinary world, I recognized very quickly that I needed to have a completely empty cup. I had some PT skill set. I put most of my early power and knowledge into therapeutic exercise. I recognized that could be a specialty thing that I could do. But to do that, I had to learn animal behavior. So I kind of picked a path that would give me traction in the veterinary world, because most veterinarians don't know anything about therapeutic exercise. It's not part of standard training. So that's kind of how I did it. And it worked well because it allowed me to have an empty cup. But what would you recommend as veterinarians for the physical therapist just entering? Like, what kind of attitude should they have? What kind of vibe should they bring to the conversation? All that kind of soft skill and hard skill stuff could you recommend?
I mean, I think it has to be about collaboration. And I think if it's not, that's going to be off-putting. So not in a way that you're going to steal my cases, but there was a question in there about like, could be a hesitation about referring to a PT. And if my answer to that would be, if they are not able to recognize, acknowledge any red flags. And so as a PT is getting started, there are medical conditions that can look like a musculoskeletal condition. And so spending time with the veterinarians and also having a relationship with the veterinarian that you can call them just in the way that Alana calls PT mentors for a PT consult, having a team of veterinarians, whether it's a general practitioner that you're getting referrals from, or a surgeon and a neurologist, a cardiologist, and internist that you can reach out to and ask if you have any questions. But I would say, go meet your especially your local specialist, because as we started talking about at the beginning, more and more there is a list, and there's a list that's going to be handed out about where clients can go for animal rehab. And if you have a relationship with that person handing out the list, it's going to be a much better experience for everyone involved. So I would say don't hesitate to knock on doors, send emails, and just try and build that relationship. But the soft skills have to include that willingness to learn, to ask questions, to collaborate, and make it truly a team approach. That's going to be the best bet for everybody.
Mm-hmm. Yeah, I mean, I would say the PTs who've interned with me, a lot of them have come back on volunteer basis after their hours are completed, just for observation. But I try to get them in to palpate things. So we're practicing skills that they don't necessarily practice, like palpation for cranial tibial thrust in a dog, so they get the feel for what does it really feel like, so they're clear. And at the same time, when they're here, I'll ask them, how would you treat this soft tissue injury? And we'll kind of share information. But a general practice or specialty practice, to hire a PT, I think they're going to incorporate a PT into the practice. They're going to want to know that you have the basic knowledge. They're going to want to work with you and get to know you. So maybe even a volunteer or a 1 day a week kind of collaboration would be helpful in the beginning.
Mm-hmm. And also, I think, Sasha, what you did, I mean, you had your sister as an opportunity, but we don't force animals to do anything. So figuring out how to get them to be willing participants in the therapeutic exercises that we're asking them to do, or to lay down for the manual therapy or the modality. Unless you have a lot of experience with animals, that may not come naturally. So working with a dog trainer or an animal behaviorist and just spending time learning how to get those techniques, demonstrating that to the other veterinarians will go a long way, versus kind of not really having the animal skills, the animal handling skills. That can be a bit of a put off too.
Mm-hmm. I will say that the number of people I work with, who I collaborate with, who are not PTs or DVMs, like a lot of sports training for agility, behavior and training, clients of mine have taken such a great interest in the anatomy, and they just really want to know, and they're great people to refer to you as a PT, because they know that you understand movement science and you understand how to train a dog with an agility, trying to go from competitive to winning, to take them through a program like your book, Sasha, how to get them trained, cross training and conditioning. I think PTs have a better sense of progressing therapeutic exercise programs and conditioning than I think mostly when I first came in as a veterinarian. I was focusing on the injuries and not on like conditioning and training. So I don't know if I'm making sense, but working with people who are in the sports medicine, working with sports enthusiasts, or if you have a dog and you are a sports enthusiast, do agility with your dog, do some of the competitive sports with your dog, so you learn about the types of injuries and things that you will see in practice. And I think that will help a lot too.
And I think two things to add to this from a physical therapy perspective, and the one that I'm most passionate about for physical therapists, is you just flat have to know your stuff. You can't go talk to an orthopedic surgeon and not know what a TPLO is or what the TPA is, or you cannot go talk to a neurologist and not be able to neurolocalize. Like, period. There's no like, oh gosh, the dog has ataxia, I think it should see a neurologist. That's a really great step A in your rehab training as a physical therapist. But in order to interface with that neurologist, you need to be able to say, I have neurolocalized to a T3L3 upper motor neuron lesion. Would you like me to refer back to you, general practitioner, or would you like me to send it to the neurologist? Like, that's a game-changing to know the language, and it's not a hard skill set to get PTs. It's everything you already know translated into the dog anatomy and physiology. So there's that. You got to just know. And then the second piece to add to it is how important it is for physical therapists when you think about practicing on animals. I was recently doing a lit review for an educational piece I'm working on, and it takes so many reps for us to learn the manual therapy skills in humans, and humans can give us the immediate subjective feedback. Now we have to learn that on a different species where they have fur and they're quadrupeds and their facet joints are not aligned the way the human spine is. And now you need to practice, practice, practice. So one of the ways I practiced when I was a brand new, hot off the presses animal physical therapist, not yet practicing because I was too nervous, which was really a good choice for me. I did these animal conditioning courses where I would just work with the dog trainers and teach healthy dogs how to do progressive therapeutic exercise. And when I did that, I added a physical therapy screen to the beginning of every single patient. So these dogs would come, they'd come with veterinary orders. So we had the diagnosis. I'd do a PT screen, and I learned, oh, I can tell the difference between a hip and an iliopsoas. I can see ataxia. Like, I learned those things. So find ways to do it legally, ethically, within your comfort zone, following all the laws of your state. And you really can learn so much if you get out there and just start building reps. I'm checking the chat here to see if there's any questions that we haven't yet answered. I think we did a pretty good job. So I think as a lead out, because we've got 5 minutes left in our fun conversation tonight, thank you both for joining. It's been really nice to hear and just to visit with you guys. I never get to just hang out with people and visit anymore. What other recommendations would you have for physical therapists who are moving into the veterinary ecosystem? Like, do you have a wish list for physical therapists? I wish PTs would know X or something like this.
I tell all of my PT interns, sign up for foreleg.com and watch videos. Go to the STAR conference and attend workshops. Do CE in the field with other PTs and veterinarians who are actually already practicing. So you develop the skills on the quadruped or just repeating it. I learned so much from those extracurricular training videos, and also the online rehab, all the online rehab resources, not just Lori's. But I find that ongoing education is so critical, and the more you do it, the more you'll feel, I think, confident in your ability to watch an animal move and see what we're seeing, those of us who've been looking at animals for a long time. So.
Yeah, I agree with all that. I think I'm just going to sort of reiterate what I said before, is spending time with veterinarians, veterinary specialists. One point I kind of want to make is that if something comes to you with a diagnosis, that diagnosis isn't always accurate. If it comes to you with a diagnosis of arthritis, that's probably not accurate. And you can do your assessment and maybe identify musculoskeletal conditions or issues. But I've had 2 dogs referred to me for stifle surgery, that had femoral artery thrombi. And so it was doing a full physical exam, feeling that there wasn't a femoral pulse in one side, and knowing that those dogs just didn't really fit the normal mold of what I would expect with a cruciate. So there is a matter of just knowing what normal is, whether it's normally abnormal or what a normal recovery from a surgery should look like. And appreciating that there can be multiple things going on. So I would say just if you get a referral, don't just assume that is exactly what is going on. So it is important to, and if I guess I would say the more that you're around animals, or more that you're in the veterinary field, you develop a spidey sense, that intuition that there's just something not quite right here. And as soon as you feel that, send the pet back to a veterinarian to make sure that we're not missing something.
And I will say that takes some self-confidence and courage, because if you're being referred from a vet and the client comes in expecting, their vet said that the vet they've known their whole life said that their dog has an ACL injury, and you're finding that it's psoas or a hip and the ACL is completely fine, it's hard to say that in a way that you don't want to throw their vet under the bus. But if you send it back to their vet, you may not get the workup that you need. So it might be, hey, let's get a third opinion. Let's have you see an orthopedist or a neurologist at that point, and let the referring vet know that you're not quite sure if the diagnosis is what they think it is. Now, here's my rule out list, which includes X, Y, Z, and, see what they say. It's tricky a little bit, the relationship. If the clients have a really good working relationship with their vet, a lot of times you'll see clients who go to these big hospitals and they don't have a regular practitioner who sees them all the time. And so it's a little easier to say, no, I think you should go to an orthopedist to confirm this, or no, I really don't think there's anything wrong with the knee. This is for sure the hip. This is for sure psoas, or we need imaging of the hips to see what's going on.
And as soon as that happens, pick up the phone and call the veterinarian. So I would say that the communication is the most important, whether you're talking to the client or whether you're talking to the veterinarian, making sure that communication stays open and that they're aware, rather than just being thrown under the bus and hearing about it after the fact.
And to Dr. Shaw's point about being thrown under the bus, I cannot reiterate how difficult it is for veterinarians to diagnose things. You guys, it's so hard. So if you get a patient coming to you, referred to you, and it ends up being something else, please, please, please do not throw your veterinarian under the bus. I work with these incredible veterinary specialists, and sometimes we're wrong. And we have all the diagnostics, and we have the smartest people in the room, and we are still wrong. So diagnostics in the animal world are very, very difficult. So really it's about making the next right decision for the pet. And if what's before you looks different than what you anticipated, pick up the phone and call your local veterinary friend. They're really nice people. They're really smart and they're funny. You should just enjoy building great relationships with them. Any parting words, doctors, tonight?
Well, I assume most of you who are interested in this field have dogs or cats or animals of your own. And so you probably have a good working relationship with your veterinarian. So that's a great place to start. Like, hey, Dr. So-and-so, I would really love to shadow you or be in on some of the, can I watch a workup or surgery, just they already know you and they already like you. So sure, reach out to them first.
Yeah, good point.
I would just say go through one of the certification programs and make friends in your class because they can be your contacts once you get out into the real world.
Yep. Exactly. Excellent points. Well, I appreciate you two joining us so much tonight. And thank you, everybody who joined us live. Really appreciate you. Physical therapists, I hope we're inspiring you to run out and meet your local veterinarians, become certified or credentialed, and join us in the animal physical therapy world. We will see you next month for the next podcast. And the team at APTA is going to send out to the animal physical therapists a list of topics that you guys might be interested in for next year. So please just take 2 minutes to fill that out so that we can send you all the information through these podcasts that you're looking for. And we'll see you next month. Thank you so much, Dr. Shaw, Dr. Struble. Bye, everybody.
Bye.